Next, I'd like to call upon Dr. Bhaskar Srinivasan from Code Eye Care Chennai, and he's going to speak on Stevens-Johnson syndrome.
A very good afternoon, and I'll be speaking on comprehensive management of Stevens-Johnson syndrome. No financial disclosures. So basically, when you're talking about SJS, it is an immune complex mediated disorder, which is a hypersensitivity reaction. It is life-threatening, and as far as ophthalmologists are concerned, it causes devastating ocular morbidities. When you're looking at the acute stage, you have a blistering disease, you have conjunctival ulcers. And in the chronic stage, you're dealing with dry eye, cicatrizing conjunctivitis, lid margin related issues, ultimately leading to ocular surface failure. You could end up having an eye which looks relatively normal to an eye which gets completely keratinized and dry, where keratoprosthesis might only be the option. So the disease itself gives us what we call as windows of opportunity to prevent it from getting worse. As far as an acute SJS is concerned, we do know now that there is a definite role of systemic cyclosporin, there is a definite role of systemic steroids, and as ophthalmologists, we need to look at the ocular surface to look for conjunctival ulcers on the bulbar or the tarsal surface. And if they are there, then amniotic membrane transplantation in the acute phase, preferably within the first week, does help in reducing the chronic phase sequelae. If you're looking at the chronic sequelae of the disease, you end up dealing with dry eye, lid abnormalities, lid margin keratinization, which is one of the points that we probably would need to highlight, because this is what significantly leads to corneal scarring, limbal stem cell deficiency, and ultimately leading to an end-stage ocular surface failure. We have published our approach on chronic SJS when we said that, okay, in the acute phase, you probably want to look at the amniotic, and this was published in 2014 in Graphes. In the chronic phase disease, you basically can categorize the patients as what you would want to do to stabilize the ocular surface, what you would want to do to tectonically stabilize the eye, and then you look at visual rehabilitation, whether with keratoprosthesis or without keratoprosthesis. So when you're looking at stabilizing procedures, you're basically looking at the use of punctal cautery, you're looking at using the mucous membrane graft to address the lid margin keratinization, use of the scleral contact lenses as such. When you're looking at tectonic procedures, you're basically looking at the use of cyanoacrylate glue, use of either a lamellar or a full thickness grafts. And visual rehabilitation, you're basically looking at options of avoiding a keratoprosthesis, which could either be with the use of stem cell-based therapy, like the Japanese did publish about the use of Comet, or you can look at even doing an optical iridectomy or a cataract to somehow improve their vision and make them self-amenable to their daily work. The option of keratoprosthesis is already there. So between 2014 to 2025, what has probably changed is we also now use Tenon's patch graft as an option for tectonic stabilization of the globe. We've used AIOS2025 as a modality for stem cell-based therapy as far as chronic SJS is concerned. And there's an increased evidence that Mikoff keratoprosthesis might also be useful in some of these challenging cases. So when you're looking at assessment of these eyes, you're basically looking at how severe is the dry eye and how severe is the lid margin keratinization. If the eye is very severe, dryness is very severe and lid margin keratinization is mild, you might just get away with a punctal cautery. But if there is significant lid margin keratinization, you might need to combine the cautery along with the mucous membrane graft. If there is a possibility of improving the vision with an optical iridectomy, with a cataract, with a scleral contact lens, you might want to try that first before deciding on doing any major surface restorative procedures in terms of Comet or AIOS2025 or a keratoprosthesis as such. So when you're looking at SJS, if you have to do a surface reconstructive procedures, you would want to preferably avoid an LK or a PK as best as possible, because the moment you do an LK or a PK, to a large extent, the success of these grafts in these eyes is not as good. When you're looking at using AIOS2025 or Comet, you probably want the eye to still be reasonably moist for the cells to survive. As far as a Boston type 1 keratoprosthesis is concerned, it's preferably avoided in eyes with Stevens-Johnson syndrome, and you would probably look at the type 2 keratoprosthesis if at all you're going down the line of keratoprosthesis. So looking at addressing the dry eye, the most simplest way of addressing that would be with a punctal cautery. Do not assume that the puncta gets cicatrized by the disease itself. Actively look for the puncta, and cauterizing the puncta significantly improves the ocular surface. This patient is 2 weeks post-punctal cautery. You can see the inflammation, which is less, and you can actually see the SPKs, which have significantly disappeared just by occluding both the puncta. When you're looking at lid margin related trauma, which causes the blink related microtrauma on the ocular surface, you can actually see that the corresponding area of lid margin keratinization and the corresponding area of increased ocular surface staining. Again, if the upper lid is involved, because the excursion of the upper lid is more as compared to the lower lid, a lid margin keratinization of the upper lid needs to be addressed more aggressively as compared to a lid margin keratinization of the lower lid. So when you're looking at decision making in terms of whether you would offer an MMG as an option, you would basically be looking at grading the lid margin, you would be looking at the patient's symptoms, you would be looking at the ocular staining, you would look at surface keratinization, and you would look at whether you are planning any intraocular procedure in terms of cataract for these eyes. So to a large extent, addressing the lid margin keratinization has become a game changer as far as chronic management is concerned, because an eye which looks scarred and vascularized, where you would have thought of keratoprosthesis as an option, significantly improves by just addressing the lid. So this patient, you can actually see the improvement in the corneal clarity, and the vascularization has reduced, and the surface staining has reduced, all by just addressing the lid margin keratinization without touching the cornea. The results are almost instantaneous. Even on day 2, you'll probably see that the eye is going to be quiet and the patient is going to be comfortable. You don't need to put them on any post-operative topical steroids. You're just going to continue the lubricants and an antibiotic for the first week. The sutures are removed generally by about a week's time. This was a patient who was using a bandage contact lens for the last 15 years because she couldn't open her eyes because of the discomfort due to the lid margin keratinization. And she'd already lost one eye due to glaucoma because of a steroid response. And this was her eye day 2 post-surgery. And the first thing that she said was, in 15 years, this was the first time that she was opening her eyes comfortably without having a bandage contact lens in the eye. So it shows the amount of destruction that the lid margin keratinization can do to the ocular surface. So this is again a patient where we had advised lid margin mucous membrane grafting for the lid margin keratinization. At this stage, the patient refused to get it done. You can actually see that the haze has increased. And then once we addressed it with the MMG, the haze has actually reduced. The vascularization has kind of settled. What is the age at which you can do an MMG? There's no preferable age in that sense. Even a child less than 1 year, we have done it. But obviously, you will want to wait for the mucosa to heal before you plan for the MMG. But if you're doing for a child, you might want to probably do both the eyes at separate times, because you might not be able to harvest as much amount of mucosa to cover all the 4 lids. If there is a recurrence of the lid margin keratinization, it probably happens because the mucosa either retracts or the mucosa gets necrosed off because of epithelium growing under the mucosa. There is no question of rejection because it's an autoimmune, it's a self-antigen there. And the management of recurrence is pretty simple. You can excise it and redo it just like how you would do a regular mucous membrane grafting in the primary instance. The most important point here is, when you are replacing a lid margin keratinization with a mucous membrane graft, the thickness has to be commensurate to the thickness that you are removing. If you increase the thickness of the tissue that you are transplanting, you are actually increasing the blink-related microtrauma on the ocular surface, because these eyes are already a little bit dry. So if you have a very thick and bulky mucosa that you're putting on the lid, you actually worsen the lid margin induced trauma, and the patients are not going to be happy. So when you're looking at SJS, you need to have all these things in mind when you deal with the patient. You need to assess the stability, you need to stabilize the surface, you need to then think whether you can do anything apart from K-Pro for restoring the vision, and if nothing else works, then the option is for K-Pro. So we'll just go through some cases. So this patient underwent a cautery along with a mucous membrane graft for the lid margin keratinization, then underwent a cataract surgery, and then was given a Prose lens. So you have to have everything in your armamentarium to give them as best an outcome that they can get. Again, a patient with HIV-induced, medication-induced SJS also had a bacterial infection. We treated the infection, did the cautery, did the mucous membrane graft, and she's stable now about 5 years, maintaining 6/6 vision in both the eyes with a stable ocular surface. A one-eyed patient with a fungal infection, treated medically, perforated, had a patch graft, then underwent an MMG for the lid margin, and then extracapsular cataract extraction with an optical iridectomy, and then we gave him a Prose lens. He's maintaining about 6/18 vision in his only eye. If there is a perforation, you would need to address that with a lamellar patch graft, as was done in this patient. And then the lid margin keratinization was addressed with a mucous membrane graft, then a cataract surgery, and then finally a Prose lens. So you have various methods of improving it. You'll need to use each of these steps judiciously. So a cataract surgery in an SJS eye has its own complications in terms of the fact that you don't want the epithelium to break, the fact that the visibility might be an issue, and you might want to use viscoelastic on the surface to enhance the magnification. You would want to use endo-illuminator or an external light pipe source for better visibility during the cataract surgery itself. You will have issues with intraocular lens power calculation. So these are cases where sometimes you might even have to actually do a conventional ECC or a SICS rather than doing a phaco based on the visibility that it offers you. This was a patient who had a small perforation, underwent cyanoacrylate glue, but the person who did the glue ended up touching the lens, so ended up having a total cataract. So we had to do the cataract surgery. But again, address the lids and then tackle the intraocular status as such. So these are some of the photos from our publication in Graphes, which basically talks about addressing the stability of the ocular surface, addressing the tectonic stability of the eye, and then looking at visual restoration procedures as such. But what would you do if you have a child who's 8 years old, bilaterally blind now because of SJS with a complete total limbal stem cell deficiency? You can't think of a keratoprosthesis because he's a child. So what are the options? So here we were thinking what we could do. We ended up deciding to open up the ocular surface and form the ocular surface with allogenic slet under systemic immunosuppression. We put the patient on both mycophenolate and systemic cyclosporine, and then we shifted it off to systemic tacrolimus. The first eye at 3 months was doing fine. There was a focal recurrence of or a failure of the slet, which you can see it actually the vascularization increasing, and we did a top-up slet, and this eye has been stable. Then we did a similar procedure for the other eye, and now it's almost 8 years. This child is now 8 years post the allo slet in both the eyes, maintaining 624 in the right eye and 69 in the left eye. So we have deferred the need for a keratoprosthesis, and we now know that we'll be able to maintain the child on allo sleds. Even if it fails, we can probably do a top-up allo slet and keep maintaining the vision for as long as we can. Another patient who was one-eyed, who presented with a complete limbal stem cell deficiency. Inferior fornix was obliterated. There was lid margin keratinization. The option was either we go directly and do a keratoprosthesis, or we try surface restorative procedures first, and if it fails, then consider keratoprosthesis. So we discussed with the patient. We said we'll try surface reconstructive procedures first. So we did an inferior fornix formation along with mucous membrane grafting. We then did an alloslet under systemic immunosuppression. He had an area of thinning here, so we had to do a patch graft in that area. Then subsequently he underwent cataract surgery, and then we gave a Prose lens. And this is how the patient ended up with. You can see the crescentic patch of tissue that we had to put here. The alloslet bits were still there. The vision improved with glasses to 612 and with a Prose lens to 6.6. There is a gradual failure of the alloslet now. His vision is still at 618 with glasses, and he's able to move around. So this is almost about 4 years now, and we've been able to maintain his vision. A type 1 keratoprosthesis is not indicated as far as SJS is concerned, but you do have the option of keratoprosthesis. But you would probably want to look at these fours. How would you prevent or delay the need for a keratoprosthesis? By addressing issues that prevent deterioration of the ocular surface. You would want to use any other modality in terms of Prose lens, minor salivary gland transplants, alloslets, optical iridectomies, cataracts, to give them some vision before deciding on K-Pro. If you're deciding on K-Pro, you would need to look at the general anesthesia fitness, the tooth status, the visual potential, cosmetic issues before deciding what would be the option. For SJS, the three options primarily would be an MOOKP or a Boston type 2 or probably the Mikoff keratoprosthesis, and we have this publication where we give a guideline in terms of what we would choose in which patient. And over this last 2 decades, we've experienced with around 130 MOOKPs that we have done and almost close to 90 Boston type 2s that we have done. And we do feel keratoprosthesis does have a role. And when you see a patient who's been able to maintain 6.6 vision over 20 years, you know that this surgery has a definitive role in our armamentarium in terms of managing these unfortunate patients. So to conclude, you remember the windows of opportunity that you have in managing SJS. You need to aggressively manage the acute phase of the disease. You need to aggressively manage lid margin keratinization to avoid an end-stage ocular surface disease issue. You need to have an algorithmic approach to the problem. Plan the keratoprosthesis that is best suited for the patient, not something that you alone are comfortable with. And the most important thing is, if you're not doing or dealing with SJs on a regular basis, please refer patients to specialists who deal with it so that at least you don't end up with an end-stage ocular surface which requires keratoprosthesis. Thank you.
Thank you, Dr. Bhaskar, for an excellent talk. Any questions or comments from the audience? Yes, please.
Thank you, Bhaskar. So, because you're giving quite high dose immunosuppression for a young patient for your AIOS-select, is there a withdrawal strategy for these type of immunosuppression? Because
So for the child, we actually, in fact, for all immunosuppressions, we keep the nephrologists in the loop. So since the preferred drug would probably be cyclosporin or tacrolimus for the cell-mediated immunity, and the mycophenolate for the antibody-mediated immunity, for the child we actually started off, and since we were hoping that the allogenic cells survive, we started the patient on systemic steroids, mycophenolate, and tacrolimus almost about a month before we took the patient up for surgery. We continued the tacrolimus for almost about a year, and then we maintained the child on mycophenolate. The systemic steroids we continued I think for about a 6-week period. There were periods where there was a failure and we had to top up the AIOS-led. Like when I showed, there was increasing vascularization. So that time we just hiked up the systemic Visalone. We did not hike up the other systemic immunosuppression. But again, whether we should have hiked up the systemic immunosuppression, those are things we probably will know as we end up doing more and more numbers.
On multiple occasions, we get a call from ICU for management of the acute SJS cases. And on those instances, like even opening the eye of those patients is really tough. Is there any specific manner you do it, sir? Amniotic membrane
So basically, the opening the eye is going to be tough because of crusts around it. So you will need to wash that with normal saline, rinse that area. The fact that the lids are stuck, if inside it is stuck, that means there's already a raw area there. It's important to stain the ocular surface, and you'll probably need to take a handheld slit lamp with the blue filter to look for ulcerations. If there is no ulceration on the conjunctiva, then there's no role of any amniotic. Then you're just going to be giving topical antibiotics. Maybe if you feel there's a bit of inflammation, topical steroids, and the systemic medication goes off. But it's important to try to evert the lids and look at the tarsal area, because you will normally, even if there's no bulbar ulceration, you'll end up having tarsal ulcerations there. So if there is an ulceration and it's within the first week of the SJS, then Darren Gregory's paper does show that doing an amniotic in these eyes does reduce the severity of the disease process as far as chronic sequelae is concerned. It doesn't prevent an LMK from developing in all cases, because it depends on the severity of the insult, but at least to the extent that you have done what is best possible for the patient.
Times I tried talking to anesthetists also, and in cases of SJS, they also they want to keep themselves.
See, everybody wants to be safe.
Definitely.
Everybody wants to be safe. The problem is at that time the priority is given for the life of the patient. But right now it is important. We now have a body of literature which states that these things need to be done. So there's good reference. You just need to speak to your. And even if they cannot, if the patient is intubated, it's not an issue. You can just put an amniotic, put a conformer, which at least keeps the amniotic in place. You can use, Dr. Shodosh has published a way of doing amniotic in the acute phase in the ICU. You can just put an amniotic, put a large bandage, contact lens, something to keep the amniotic there so the anti-inflammatory effect of the amniotic sets in. You will have to then think out of the box to try to see how and what best you can do for the patient. But not doing anything in that stage means they will come out of the disease, but they will be bilaterally blind, and then it becomes a very difficult situation as such.
We're overrunning quite a bit. Can we, just one last question from GA, please. This is the last question. We have to move on to next talk. We're overrunning quite a bit.
I have one question. Why do you recommend not to use steroid after MMG? After mucous membrane grafting, many antibiotics do you use?
I didn't get the question,
Why,
ma'am.
why not to give steroids after doing the mucous membrane
You
graft for
don't
the
need
allergy?
you don't need steroids. The inflammation is primarily because of the lid margin. So in fact, on day 2 itself, the eye is quiet. So when you don't need steroids, you don't. Unless there's a lot of inflammation or you've done a lot of dissection here, the dissection plane is between the tarsal surface and the conjunctiva. You're not dissecting anything else. So most of these eyes kind of settle down by day 2, day 3 by itself. You really don't need, they're comfortable, so you really don't see any inflammation or the need for us to use topical steroids or systemic steroids.